All right, so now we're going to talk about respiratory issues in kids. Big topic, big content section. You're going to see a lot of respiratory illnesses when you go to the hospital. So we're going to go through the PowerPoint first because the PowerPoint just touches on some, it's very high altitude look. So we're going to go through it pretty quickly and then we'll focus on the chapter. There are certain things that you're going to see more of with respiratory disorders. You're going to see a lot of asthma, you're going to see pneumonia, you're going to see bronchiolitis, you're going to see the common cold, cystic fibrosis, and pneumonia. So those are kind of the things that we're going to spend most of our time on. Some A&P about child's anatomy. Their nose. Okay, so they're obligate nose breathers. That means, and this says they cannot open their mouths to breathe. They can, but they don't like to. So they try their best to breathe through their nose. Now, their little nares are very narrow, and even though they don't have a lot of mucus, a little bit of mucus goes a long way. So if you've got a snotty baby, you've got an airway problem. So make sure that, let me back up just a little bit. Everything with respiratory kind of goes the same way. You want to clear the airway, okay? So if they're having a hard time breathing, you suck out their nose because they only breathe through their nose. Their throat, their tongue is big compared to their mouth. So airway obstruction, if their tongue gets in the way, could happen. They have big tonsils in proportion to the rest of their mouth, so just keep that in mind. Here's some sizes about their airway. Now you can imagine just a little bit of mucus in there, like I said, goes a long way. Also, if they have some swelling, like asthmatics have a couple of different things going on. They have mucus production and then they have swelling. So they have constriction, swelling, so a little bit of swelling can really do some occluding to the airway. Lower respiratory structures, you have a smaller number of alveoli, so you have less surface there to transport oxygen, so just keep that in mind. All right, so when you are assessing the respiratory system, inspection and observation. So when you walk into the room, you're going to do a kind of across the room kind of look. Getting a rate and getting how they're working, you know, their work of breathing probably needs to happen before you lay your hands on them because that's when you're going to get your more true assessment. Look at their color, okay? Cyanosis, not good. Pallor, not good. Rate and depth of respirations. Look and see if they're retracting. If you can tell that by, you know, your kind of across the room assessment, you can get a rate. You want to assess their nose and their oral cavity. Is there a lot of mucus? You want to listen to them. If you hear obvious stridor coming from across the room, then you know you've got something blocking that airway. Look at their effort. Look and see how anxious they are. If they're restless. Key point, restless. Think of your respiratory and your oxygenation status when you hear the word restless, okay? And it's going to come up in adult. It's going to come up in PD. If they're restless, that's not good. Clubbing. Clubbing, there's some really good pictures in the book about clubbing of the nails. It's a chronic hypoxic state that causes clubbing. And then their hydration status. If they're crying and there's no tears, then that's a problem. All right, when you're listening to breath sounds, you're going to hear about 3 different classifications of breath sounds. Wheezing, okay? Wheezing occurs when there is bronchoconstriction and swelling of the inside of the bronchiole. Okay, so a couple of different things going on to hear. So you'll hear that wheezing. You hear it in asthma. You can hear it in bronchiolitis. So no wheezing. I think there's some, yes, there are some links to some breath sounds. So make sure you listen to the wheezing ones. Rails or crackles, that's heard more with pneumonia, and that's when there's fluid down there. You'll also hear stridor. Croup kids have, or kids with croup, stridor is what you're going to hear. Now, if you hear inspiratory and expiratory stridor, or stridor at rest, those are all signs of increasing respiratory distress. All right, I don't like that question, so we're going to skip that. All right, some tests that you might see ordered for respiratory disorders. All right, pulse oximetry. If a child comes in and there's any kind of respiratory complaint, they're going to get a pulse ox. So oxygen saturation with obstructed airways, as you can figure out, it might be decreased. Anything above 90 is where we like to hang. We like to hang above 95, but anything above 90, no oxygen necessary, no supplemental oxygen. Once it gets below 90, unless you have other specific orders, then that's when you need to think about oxygen supplementation. Chest x-ray, so you might be looking for a pneumonia. So you probably see a chest x-ray done if you have a respiratory complaint. Blood gases, we do capillary blood gases in kids if we need to, okay? The whole ABG, big needle in the wrist thing, doesn't happen a lot with kids. Nasopharyngeal washings, nasal washes, we do those for testing for RSV or the flu. And then rapid strep, you might see it done with a throat swab or a throat culture. Usually when we do a swab, a rapid strep, we always do a culture just to confirm negative or positive. We talked about pulse ox, and this is specific for pneumonia. With a pulse ox, or with a pneumonia, especially like a mycoplasma pneumonia, you might see hypoxia. Chest x-ray, looking for effusions or opacities. Sputum culture. Kids are a lot of times unable to provide you with a sputum culture, so sometimes they do a swab. With cystic fibrosis kids, they'll do a swab if they can't cough anything up. And then white blood cell count, you might see a CVC drawn. Of course, it would be elevated with the pneumonia, and then according to the differential, they can tell whether it's a viral or a bacterial situation. All right, some labs specific for CF, cystic fibrosis. The sweat chloride test is basically, and the PFTs, you'll see those done with CF kids. Sweat chloride test, when we talk about CF, it's a chloride transport defective gene. So they look for chloride, sweat chloride. So they take a some stuff that they sprinkle on the skin, and it makes the patient sweat, and they measure the level of chloride in their sweat. So 50 above 50 is suspicious, and above 60 is diagnostic. Pulse ox, chest x-ray, they do both of those with cystic fibrosis kids. And then pulmonary function tests. Each checkup that they go to the doctor, they do a pulmonary function test, and they get a baseline, and then they they measure it every 3 months, and just to see kind of where they are with their PFTs. All right, some common treatments that you might see. Oxygen. If we go below 90%, we're going to need some oxygen. Now, the exception for this is if you have a cardiac patient, sometimes their normal oxygen saturation runs very low. So if you have a cardiac history, then you rethink the oxygen. Otherwise, if they're below 90, get some oxygen on them. High humidity to kind of moisturize the whole upper respiratory tract. Suctioning, suctioning, suctioning. You will bulb suction many babies in your clinical time. Chest physiotherapy and postural drainage, that's to kind of break up the mucus. When we talk about cystic fibrosis, you'll talk about their treatment methodologies, and their regimen is they do a bronchodilator, then they do a mucus thinner, and while they're doing the mucus thinner, they do chest physiotherapy either with a vest that vibrates them or by hand. You can pat on their back with your cupped hand, and it kind of helps break up all that mucus and helps them cough it up. Saline gargles or lavage if you have a sore throat or strep throat, those are helpful. Mucolytic agents to thin mucus. Chest tubes if you have an effusion, if you have a big empyema from a pneumonia, which is just a big collection of bacterial nastiness, you might have a chest tube in. Or if you have a pneumothorax and you have air in there, you might have a chest tube in as well. Bronchoscopy to go looking for the problem. Sometimes foreign bodies get lodged in lungs, and we have to go get them with a bronchoscopy. All right, I'm going to skip that. Some acute infectious disorders that you're going to see with respiratory patients. The common cold is the most common. Sinusitis, there's, everybody thinks that their child has a sinus infection if they have yellow mucus. Not true. There are some criteria that you have to meet in order to be diagnosed with a true sinusitis. Flu, it's not flu season. It may be flu season. Flu season lasted a lot longer this year. So we'll talk a little bit about the flu, and I think we've talked about that some in our immunization podcast as well. Pharyngitis, tonsillitis, and laryngitis. Strep throat kind of falls into that category. You can have a bacterial tonsillitis or you can have a viral tonsillitis. So different bacteria and viruses can both cause swollen tonsils, white patches on tonsils, etc. Croup syndromes. Croup is inflammation of not really the upper airway, but just right at the back, not lungs. You won't hear wheezing with croup usually, but you hear stridor because the swelling is right there at the carina. So we'll talk about that. RSV. Now RSV is actually the virus name. It causes what's known as bronchiolitis. So it's a causative agent of bronchiolitis, and it is viral. So you do not treat that with antibiotics. Okay? Actually, you don't treat RSV anymore with anything. They used to give breathing treatments, steroids sometimes, but that's even been not contraindicated, but it just doesn't offer much improvement. And then pneumonia and bronchitis. You can have viral pneumonia, you can have fungal pneumonia, you can have bacterial pneumonia. Bronchitis is usually viral. All right, some risk factors for respiratory disorder. You have kids that are at higher risk for developing or for getting sicker with respiratory disorders. Preemies, of course, they have their lungs sometimes aren't as mature as they should be when they're born, so they start out behind the 8 ball. So sometimes they struggle with respiratory disorders, especially in the winter. Chronic illnesses such as cystic fibrosis, congenital heart, babies, those with chronic lung disease. And chronic lung disease used to be known as BPD, bronchopulmonary dysplasia. And we'll talk a little bit about that over in the chapter. Developmental disorders, movement disorders like cerebral palsy. Sometimes they have a hard time mobilizing their secretions, so they're a little bit more prone to respiratory infections. Of course, smoke. We talked about that in the ear, nose, or the ears, eyes and ears module. That irritates the upper airway, and that can cause inflammation, lead to ear infections, etc. Immune deficiency, that's kind of a no-brainer. If your immune system's down, then you are more prone to picking up those respiratory issues. Crowded living conditions, more people in the house, more germs to spread. And daycare attendance. Now, I know daycare attendance is kind of controversial, but it does build up the immune system. So at first, the baby might be sick a little bit more, but that immune system is growing every day, fighting off those germs. So not necessarily a bad thing. All right, bronchiolitis is just what it sounds like. It's an inflammation of the bronchioles, usually caused by a virus. There's a lot of mucus involved with bronchiolitis. It usually starts with a clear runny nose. You can hear some wheezing. Fever, not a huge high fever, but sometimes they have fever. And it is long. It lasts at least a couple weeks. So good teaching with bronchiolitis. If you send parents home with a child with bronchiolitis, first of all, they're going to be scared to death because they've seen those horrible commercials on TV of those tiny babies that are in the ICU because they have RSV. So you have to dispel that myth, and you have to say this is a totally manageable disease at home. What you're going to do is you're going to suction your baby, you're going to clear the mucus, and you're going to wait for this to run its course. You're going to see poor feeding because their noses are blocked up. And remember what I said, they're obligate nose breathers. Okay? And those at high risk, like congenital heart patients, preemies, there is a vaccine available that they'll do during the winter. It is very, very, very expensive. The trade name was Synagis for a while. I don't know if there's a newer one, but it's like $4,000 a shot. So it is quite costly. However, it's not as costly as an ICU stay for a baby. All right, TB, we're really not going to focus a lot on TB because it is one that you probably won't see in pediatric patients. All right, a pneumothorax. So a pneumothorax, or collapsed lung, as you probably have heard it called, signs and symptoms. So these kids come in with chest pain, okay? Respiratory distress, no adventitious sounds. However, they may be diminished in the area where the air is, you know, the lung tissue is not moving. So trauma is a risk factor for pneumothorax. Sometimes they're just spontaneous, especially in those teenagers that have that long torso. You know, we had one that came in that was out mowing the yard, and all of a sudden he got horrible chest pain, came in, mom brought him to the ER, we x-rayed him, he had a pneumothorax on one side. So it's just spontaneous. A lot of coughing can cause a pneumothorax. So patients with something chronic lung like CF, sometimes they can spring a leak and get a pneumothorax. Some chronic respiratory disorders that you'll see patients with: allergic rhinitis or seasonal allergies. I think everyone in Texas has that. Asthma, you'll see a lot of asthmatic patients. Chronic lung disease, like I said, that used to be known as bronchopulmonary dysplasia. That is when a premature infant is ventilated very early, and it kind of makes those lung tissues very, well, less compliant. So they don't move as well. They don't clear secretions as well. They don't oxygenate as well, and it is a chronic disorder. Okay, and then cystic fibrosis, we will talk about that in detail. And apnea, I don't know if I've ever seen a chronic apnea patient, but apnea is the cessation of breathing for more than 20 seconds. Patients with head injuries sometimes could have chronic apnea. That's about the only example I could come up with right now. All right, when you're talking about asthma, there are classifications of asthma, and it's classified by severity and the frequency of symptoms. So you have mild, moderate, and severe, and then you have intermittent or persistent. So persistent severe, it's pretty limiting, pretty debilitating. Mild intermittent is something like allergy-induced asthma or seasonal. You know, when the cottonwood blows, they have asthma. If they're allergic to cats and they're around cats, then that would be a mild intermittent asthma. All right, we're not going to talk about pulmonary function right now. All right, let's talk a little bit about CF. In the hospital, kids with CF usually come in for a 2-week stay. It's called a tune-up. So you may see these kiddos in the hospital over the summer. They're not in school, so if they need a tune-up, then summertime is a good time for them to come in and get that out of the way. So you may be taking care of these patients. CF is genetic. It affects both the respiratory and the GI systems, and it makes all mucus thick, okay, because it's a chloride transport, chloride transport defect, and it doesn't let the fluid in and out of the cells like it should. So everything is thick. Anywhere you have mucus, nose, lungs, gut, everything is thick. There are probably over 1,000 different mutations since it is genetic. It takes 2 people with the gene in order to have a patient affected with CF. So you'll have 2 copies of the gene. Delta F508 is the most common, and 2 delta 508s genes together is usually the patients are sicker. Okay, the less known or the lesser known mutations mixed together usually are more well. So that's kind of how you don't need to know that. That's just extra information. Okay, so going back to the mucus. So if you think about wherever there's mucus, that's the problem. That's where you're going to have problems. Lung, bacteria love mucus, right? So frequent pneumonias, airway clearance issues, mucus clearance issues, because everything is so thick. So our goal with treatment is to thin secretions and mobilize secretions. Okay, and that's in the respiratory system. The GI system, so the pancreas produces pancreatic enzymes, and they're dumped into the gut to help digest food and absorb fat. Well, there's mucus there. So if mucus clogs that pathway up, then those pancreatic enzymes can't get to the gut to help digest the food and absorb the fat. What you'll see with cystic fibrosis kids, failure to thrive because they're not absorbing their fat. Well, they have to take pancreatic enzymes to supplement so that they will absorb their fat. Also, you have different vitamins that are fat soluble, A, D, E, and K. Okay, those are all fat soluble vitamins. You need to remember those. Those aren't absorbed if you're not absorbing your fat. So those pancreatic enzymes that they have to take with each one of their meals help to absorb A, D, E, and K and help to absorb fat so that they will gain weight. Okay. GI symptoms include decreased pancreatic enzymes. GI symptoms also can include very fatty, nasty stools. Okay. If the fat is not absorbed in their gut, where does it go? It comes out. So you see fatty, greasy stools, floating stools. So if you have a patient with CF, you'll always want to make sure that you ask that nasty question. You know, what does your poop look like? They are so used to it, trust me. All right, we'll touch a little bit more on CF when we get back over in the chapter. Some methods of oxygen delivery. You've got about 3 different ways that you're going to put oxygen on kids. You've got your nasal cannula, which is can go up to about 4 liters. I've seen it down as low as like 1/8 of a liter on a tiny infant. Then you've got your simple mask, which 6 to 10 liters. So you want to start a minimum of 6 on your simple mask. And then a non-rebreather, which is the one on the right. It's 10 to 12. So you crank your oxygen all the way up and put your non-rebreather on the kiddo. There are other methods like a Venturi mask and an oxygen tent that they mention in the book. These are the 3 that you're going to see most likely. We're going to skip this. All right. Who notices the typo? Nursing management of, this should say epiglottitis. Epiglottitis is caused by the same bacteria that the Hib vaccine, Haemophilus influenza B, prevents. So we see less and less epiglottitis because of the vaccination for it. However, when you do see it, it's an airway emergency. Don't look in this kid's mouth. Leave that kid sitting right in mama's lap. Give them 100% oxygen non-rebreather if you can get it on them. If you make them mad, then be careful with that. Let mama hold it for a blow-by. We used to have to call, and I don't know that this is still in effect, an epiglottitis alert if we ever had a patient that we suspected that had epiglottitis. We would get anesthesia there because basically if you have an airway occlusion, you have to trach this poor baby. There's no way of getting around it. There's no way of intubating if that swells up. So if you ever hear that, you'll know that it's definitely an emergency. Okay. Again, never called one in a child. I have had one epiglottitis alert in an adult when I was in the adult ER, unvaccinated adult female, and we did call an epiglottitis alert on her. All right, so tonsils, this kind of jumps around a bit, but post-tonsillectomy. If you have a chronic offender with strep throat with tonsillitis, then you may, or the ENT may opt to take tonsils out. All right, so post-tonsillectomy, I want you to remember this. If you have a patient that is frequently swallowing, that just keeps swallowing, and I'm talking the immediate post-op time, if you see them just swallowing, what do you think they're swallowing? They're not swallowing their spit. They could be swallowing their blood. So you want to think, are they bleeding? Are they bleeding? Are they bleeding? So you want to make sure you assess the oral cavity as best you can and notify someone ASAP because we don't want them to get hypovolemic or shocky because they're bleeding from their surgical site. Pain medication, pain control, and hydration are very important post-tonsillectomy. If you're going to see, other than the immediate post-op period, if you're going to see a patient start to bleed after their tonsils come out, you're going to see it about 10 days when everything starts to slough off in the back. So if you have a patient that returns 10 days after their tonsillectomy and they say, oh my gosh, all of a sudden we're spitting up blood and vomiting, then they could be bleeding and they may have to go back to the OR to cauterize those lesions. All right, some other things that are non-infectious with respiratory, with relation to respiratory, epistaxis, bloody nose. Actually saw a patient not too long ago that had to have a blood transfusion from a bloody nose. They use these horrible torture-looking devices called nasal tampons to stop this sometimes. Sometimes they even apply, believe it or not, we used cocaine, liquid cocaine to vasoconstrict those vessels in the nose, put the nasal tampon up there, and it's just exactly what it sounds like. And that's how we stopped the bleeding. But it can get as severe enough to have a transfusion, so not something to take lightly. Foreign body aspiration, I talked about earlier, things in the lungs. Kids aspirate, they have things in their mouth all the time, so you could see a foreign body either in the lung. Most of the time it goes to the gut, but it could be a surgical thing where they have to go in and get it with bronchoscopy. Had an adult one time that he was an older adult and he had dementia and he ground his teeth, is that the proper English? Anyway, one came loose, he aspirated, it went into his lungs, and they had to go in there and surgically remove that. And then we talked about pneumothorax. All right. And this is the last slide. Interventions to minimize psychosocial. You know, we had to throw this in there. Chronic respiratory conditions. All right, kids with asthma and with CF are probably the ones that we're talking about when we have chronic respiratory conditions. What you want to remember is to make sure normalcy, okay? We want to promote normalcy. We want to help the family, we want to educate the family, but we want this kid's life to be as normal as possible. So make sure that that's where your focus is, especially in the teenage years. You know, you want to make them not set apart from their peers. So normalcy is a good thing. All right, so let's go over to the chapter. Give me just a second while I get my open here. There we go. Okay. Sorry about that. One second. There are several charts that I want to make sure that we go over really well in this chapter. Okay, this just talks about what we've already talked about as far as the differences in the nose and throat and trachea. Congenital laryngomalacia, tracheomalacia. It's scarier than it really is. It sounds scarier than it really is. When babies are born in floppy airway, you might hear it called that. It's very benign. It's the cartilage in the throat, in the larynx there, that isn't mature. So when they breathe in, you hear this awful stridor. It usually goes away by 1 year, but it scares parents to death. Lungs will be clear, their saturations will be perfect, but they do get very anxious when they hear this noise coming out of their baby. Feeding time, sometimes you hear it a lot worse when they're feeding. So just read through that box there. All right, I'm going to whip through this right here. All right, nursing process. Now, right in the middle of this nursing process are common medical treatments, and we'll talk a little bit more about those. But with the nursing process and with any of our systems, you know, now we're into the system, so this will apply to every system. Your assessment, okay? What is it going to look like? When you're doing your assessment, the best place to do your assessment is wherever the child will be the most still. So if that means in mom's lap, that means in mom's lap, okay? You want to do your across-the-room assessment first. You want to look at their color. You want to look if they're agitated. You want to look at their rate, their work of breathing. All that you can pretty much tell by not laying your hands on that child. So this goes over health history. One thing that I'd like to touch on, if you have a child that's wheezing, asthma can tend to be an allergic response. So think about if you have a child with asthma, with eczema, with allergic conjunctivitis. Okay, those are all allergic things. So there's kind of a triad. If you have a patient with eczema and asthma, and they come in with itchy, watery eyes, you're not going to really think about bacterial conjunctivitis. You're going to think more allergic. So just kind of keep that in. Those kind of go together, those three things. All right, assessment. You'll also need to listen to lungs, okay? You listen stethoscope to skin, okay? You listen in all areas of the lung, front and back, okay? You assess for retractions, and we'll talk about retractions in just a second. So you can go through the nursing process here with your assessment. All right, right in the middle here is common medical treatments. So let's touch on a few of those while we have it in front of us. Oxygen. We talked about the 3 different ways of oxygen application, and you need to know those values. 0 to 4, or up to 4 liters per minute on a cannula, 6 to 10 on a simple mask, and then 10 to 12 on a non-rebreather. Suctioning. Always make sure that you use saline when you're suctioning a patient. Nasal suctioning I'm talking about now. Saline drops in each side of the nose. Let them sit for just a second, and then get pretty aggressive sucking that stuff out of there. There's some good pictures in the book, but it's more impactful if you see it in person. Chest physiotherapy, we talked about mobilizing secretions with CF patients, with pneumonia patients too. Saline gargles, we talked about all those. All right, some common meds that you might see given. Now, there are a lot of respiratory meds, and they act a lot differently. So expectorant is going to help you cough, or help the patient cough things up. Okay, so it makes it thinner, makes it easier to get rid of. Guaifenesin is the best expectorant, and it just makes you cough. So think about it. Do you want to give an expectorant right before bedtime? Well, no, you don't. Cough suppressants, got to be careful with cough suppressants too. If you have a productive cough, you don't want to give cough suppressants, because the whole idea of treatment is to clear the airway, right? So you want to clear the airway. You don't want to suppress that cough. You want them to cough it up. Chest physiotherapy will encourage them to cough. Drinking lots of water, that'll help them the secretions, get them out of there. Every respiratory illness is treated, if you could just think of it that way, think, I've got to clear the airway, I've got to clear the airway. What do I need to do to clear the airway? Antihistamines. Antihistamines dry. Okay, so if you have a clear, runny nose, then you might want to dry. However, if you dry all of those secretions up, then you might increase their chance of getting an ear infection. I'm sorry, my notifications are popping up. I did not turn those off. Thick mucus. Bacteria love thick mucus. Okay, so if you have a lot of thick yellow mucus, you probably wouldn't want to do an antihistamine. You would want to do more of a decongestant. Okay, because you don't want to thicken those secretions. Antibiotics. If there is something bacterial going on, then absolutely antibiotics. Unfortunately, we probably overtreat with antibiotics because we can't really differentiate between a viral illness and a bacterial illness. So a lot of resistance is probably built up by treatment of a bronchitis by an antibiotic. You know, everybody that has bronchitis gets a Z-Pack, I think. There are inhaled antibiotics. Tobramycin is one that they use with cystic fibrosis patients. Beta-2 adrenergic agonist. Beta-2 agonist. That's your albuterol, your Xopenex. Those are bronchodilators, and they're used as rescue inhalers. Okay, So they're acute relief bronchospasm. The beta-2 adrenergic agonists, the long-acting ones, are more for maintenance of asthma. They're not rescue inhalers. Okay. Racemic epinephrine is something that you'll see given for croup, and it reduces that inflammation right there at the back of the throat, right above the carina. That's where you have the swelling with the croup virus. And croup is viral. We'll talk about croup syndromes here in a second, but it is viral. No antibiotics necessary for croup. Some other things that you might be see being given, Tamiflu for flu, and it says treatment and prevention of influenza A. I don't know that it's so much prevention. But it does shorten the course if you catch it within the first 48 hours. So Tamiflu, people have different opinions about Tamiflu. If you catch the flu virus, if you diagnose it definitively within the first 48 hours, then Tamiflu may have a little bit of effect. Corticosteroids, you'll see a lot of steroids given, especially with asthmatic patients. You either have oral steroids or inhaled steroids, or you can do IV steroids if they're really in a lot of distress. Inhaled steroids like Symbicort are for maintenance of an inflammatory process like asthma. Oral steroids are more in a short little burst. You usually have 5 days of oral steroids, and it's for a more acute situation. Decongestants, my favorite. Decongestants help thin mucus and help get it out of there. Okay, so if you have a lot of stuffiness, we want to promote that drainage. Now, I know that's not what parents think. They want to dry everything up. They don't want their baby's nose to be runny. But if it's yellow and we need to get it out of there, then let's get it out of there with some good decongestant. Leukotriene receptors, again, an allergy type situation happening there. Singulair is a leukotriene antagonist. It is great for people that wheeze with, or that have allergies that wheeze with their allergies. So that's one of the uses for that. Let me see if there's any more common ones down here. Inhaled pulmonary enzyme, or Dornase alpha. It is a thinning medication. It thins out the mucus. Also hypertonic saline, which isn't on here. It's a 7% saline solution. Okay, so now you're going to have to go back and draw on your pathophysiology knowledge. If it is hypertonic, it's inhaled into the lungs. Which way which way is the fluid pulled? Okay, it's hypertonic, so it pulls fluid into the lungs and helps thin out that mucus and helps them cough it up. Okay, hypertonic saline. All right, so here's some more assessment information. Of course, you want to assess the color, their color. Now, here's the information about retractions. You need to note the location of retractions. There's 5 different areas that I want you to know where the retractions are. Suprasternal is right above the sternum, exactly what it says, or what it sounds like. Supraclavicular, right up above the clavicle. Intercostal, probably the most common one that you'll see. And that's just in their little ribs there. Substernal, right below the sternum, and subcostal, right below the rib cage. The higher the retraction, the more pronounced the respiratory distress is. So if they have suprasternal and supraclavicular retractions, they're working pretty hard to breathe. All right, here's some good pictures of clubbing. And again, clubbing is from chronic hypoxia. Okay, so CF kids sometimes have some clubbing on their nails. Older people that have, I know it has nothing to do with PD, COPD might have some clubbing on their nails. All right, this talks about breath sounds. Percussion and palpation, don't really see that done a lot with kids. If you suspect like a pneumothorax, or if you suspect a fusion, a big pneumonia, then you might hear some flat or dull sounds. All right, here's some testing that's done with respiratory kids. ABGs, we talked about that, doesn't happen very often. Usually do capillary blood gases. Let's see if there's anything on here that we have not talked about that we need to talk about. Rapid flu test, rapid strep test. Rapid strep test tell you positive or negative pretty quick about strep. If there's a negative strep test, we usually send a culture away to make sure we didn't get a false negative. Rapid flu test, they'll test for the flu for a while in flu season, and then they'll stop testing for it. So it's pretty reliable. But again, if you're not within that first 48 hours, this says 24 hours, but in practice it's 48 hours. If you're not within that first 48 hours of symptom onset, then medication doesn't do you much good. Sputum cultures, we talked about that. Usually that's done with a culture, not a sputum sample, but more a swab culture. All right. So your nursing diagnosis for respiratory kids, ineffective airway clearance. If you can think about ineffective airway clearance and clearing that airway, then you're 75% there, okay? Talked about oxygen delivery. There's our pictures again. And there's a good chart, I think it's coming up right here, that talks about all the other different methods of oxygen delivery. But the three you need to focus on: simple mask, nasal cannula, and the non-rebreather. Those are the ones you'll see most often. Common cold. All right, most common respiratory complaint is a common cold. That's probably the biggest chief complaint that we see in the emergency department, upper respiratory symptoms. Caused by viruses usually, most always. Lots of different viruses can cause it, including the RSV virus. So RSV can definitely cause the common cold. All right. This is a very interesting chart just for your own knowledge and maybe testing knowledge too. I talked about earlier, every parent that has a yellow runny nose, mom says sinusitis. Not necessarily. 10 to 14 days of illness, then possibly sinusitis. But not always, because if you have yellow drainage, doesn't always mean you have sinusitis. So this is a nice little chart to kind of use when you're teaching parents about that. Clearing the airway, nasal suction with saline, treating the symptoms such as the fever, treat them with Tylenol, Motrin, and do it for 10 days. All right, here are some things that you need to point out to parents that if these were to happen, then you may need to have your baby reevaluated, okay? So if any of these things are noticed, reinvestigate. Here's our bulb suction pictures. Doesn't really look like that when you put saline drops in because they come in a nice little vial now. And then you really get aggressive when you suck out that nose. Teach parents to get off in there. They're not going to get anything just barely sucking on the outside of the nasal passage there. You've got to kind of dig deep, for lack of a better term. Here's some information about antibiotics for the common cold, and the fact that it does happen leads to more antibiotic resistance. More information on sinusitis and flu. Pharyngitis, again, can be bacterial or it can be viral. This is a nastiness, probably strep. If you see the little petechiae on the palate, on the soft palate, sometimes that can be indicative of strep too. All right, and tonsillitis, again, viral or bacterial. Most of the time it's viral. What are you going to do? You're going to promote airway clearance. Okay, you're going to give Tylenol, Motrin for fever control. You're going to hydrate. Those are all important. Mono. Mono is a viral illness. It is self-limiting. It's caused by the EBV virus, the Epstein-Barr virus. It's passed by drinking after different people, or we had one whole volleyball team one time that came down with mono because they all were drinking out of the same water bottle. So that's how it's passed. That's why it's called the kissing disease. most of the time they present with sore throat, belly pain. Their spleen can be enlarged. It's something that you may see if you're out in primary care. You definitively diagnose it by a monospot, which is the lab test, and you treat it with nothing. So it's a viral illness. Laryngitis, loss of voice, read through that. Croup. Okay, here's some good information about croup. If you've ever taken care of a patient with croup, you know that stridorous sound. Croup can be worse at night. A lot of times if parents bring their child with that barking cough, that is very hallmark of croup. Sounds like a seal. But parents will bring their child to the emergency department in the night, and they'll come out in the cool air, and by the time they get to the triage, their child is all better because the coolness and the humidity as they're breathing that in reduce that swelling in that area. So the croupy cough and the stridor is gone. Now, using that information, how do you treat croup at home? Well, you tell parents to take them into the bathroom and turn on the shower and just sit in the bathroom and let them breathe in that steam, okay? Open the freezer door, let that cool steam, let them breathe that steam in. That's going to help soothe those swollen areas in there, and it's going to make them sound a lot better. Now, occasionally they have such bad stridor that they have to have a racemic epinephrine treatment to reduce that swelling. If that's the case, if they come to the emergency department and have that epinephrine, it's given by a breathing treatment, then they stay a couple of hours because you can have what's called rebound swelling. And if they go a couple of hours and don't get the stridor again, then they're good to go. A lot of times it's treated with a steroid or Decadron, and that reduces the swelling in the airway. All right, and there's some information about home care of croup. Epiglottitis we talked about. Epiglottitis can be, we've seen a reduction in epiglottitis because of the Hib vaccine. That information is, I don't think it's in the chapter, but that's a freebie. All right, I do want you to read through this information on bronchiolitis. Know that RSV and bronchiolitis, they use them interchangeably, and they even do in this text. However, RSV is a virus that causes bronchiolitis. Other viruses can cause bronchiolitis. All right, real important, the nursing assessment with the child with bronchiolitis. Management, again, management right now is just clearing the airway. So first you need to teach your parents that this is going to last a while, and you need to manage, this is how you need to manage your airway. You need to bulb suction. You need to provide humidity in the air. You also give them what they need to look for if they need to bring their patient back. If they are worsening, their symptoms are worsening, if they're breathing more than 60 times a minute. So you need to do some really good teaching if you're going to send these kids home with bronchiolitis. All right. Here's some nasopharyngeal suctioning information that you can share with parents. All right, pneumonia. A couple different kinds of pneumonia, or 2 or 3. You can have bacterial pneumonia, you can have a viral pneumonia, and you can have a fungal pneumonia. That's not seen very often. Aspiration pneumonia is another one. It's not pathogen related, but it can happen. Again, here's some information that you need to collect during your health history. These are all very good points, so I pay special attention to them. Preventing aspiration. If you have an infant that's breathing more than 60 times a minute, you don't want to feed them. Okay, you want them to be NPO because the risk for aspiration. Okay, so remember that. Bronchitis. Bronchitis is usually viral in nature, but sometimes you can see some mycoplasma bacterial bronchitis. That's why when you say bronchitis, they throw a Z-Pak at you, because Zithromax is very effective at treating mycoplasma pneumonia. TB, we're not going to touch on TB because, again, you don't see a lot of it with kids. All right, bloody nose, we talked about that. Foreign body aspiration. What do you think the key is with foreign body aspiration? Prevention. Okay, so lots of teaching. There's a pretty picture of something in that poor child's airway. Latex balloons, that's why latex balloons are no longer allowed in hospitals, because they're an aspiration risk. This talks about respiratory distress syndrome, and that kind of goes along with the immature lung situation, prematurity, deficiency in surfactants, okay? It kind of goes along with bronchopulmonary dysplasia, those types of syndromes. Managed initially with respiratory support, and then they usually are chronic lung patients. They usually are seen by pulmonary, and they have a regimen that they, go by steroids, inhaled steroids to prevent any kind of inflammation, etc. So I'll let you guys read through that. There is a picture of a chest tube, albeit a very old chest tube. But there's some good information out there on the current chest tubes that we use. We were looking at some the other day on YouTube. So there's some videos out there you can watch if you're interested in more information about chest tube. You'll get more information about a chest tube in Dr. Reed's wonderful course coming up soon, I'm sure. All right, and then I know that this podcast is going on and on, but respiratory is a big topic, so we're almost done. Allergic rhinitis. Allergic rhinitis can lead to things like ear infections. They can exacerbate asthma. They can cause sinusitis. So important to control them. Will you ever cure them? Most likely not. Kids do grow out of some allergies. Allergies get better as they get older, but once allergic, pretty much always allergic. So you want to control the symptoms. If you use an antihistamine that works for you, great. That'll kind of keep everything dried up. Something like a Singulair, like a leukotriene inhibitor that will reduce that response, that will help. Avoiding your allergens, that will definitely help. A good history is very important with a child with allergic situation. Asthma, allergic rhinitis, atopic dermatitis, remember they all go together. Those are all called atopic or atopic disease, I guess, for lack of a better word. But those are all atopic situations. All right, I'll let you read through that. Control your exposure to allergens. That makes sense. Stay away from smoke. Pets are chronic offenders. Cockroaches. I didn't know this until I started teaching the PD course. Cockroaches shed stuff, and they are very high in allergic response. So inner city kids a lot of times have allergies / asthma related to conditions that might involve cockroaches and dirty situations where their environment is just not very clear. Lots of smoking, etc. All right, here's your classifications of asthma. Asthma is the #1 chronic respiratory disease that you'll see. Do go through this chart and note the intermittent, the mild persistent, moderate persistent, severe persistent. Okay, know what symptoms you're going to see with each one of those. Pathophysiology of asthma. It is inflammation, bronchoconstriction. So you've got things pushing from the inside out and things pushing or squeezing from the outside in. Double whammy. So the way that they treat asthma, they bronchodilate. Okay, so albuterol, Xopenex. That opens the airway from the inside. Then they have to do something it doesn't open it from the inside. That deconstricts, okay? It dilates those bronchioles. The steroid part of it, like prednisone or inhaled steroids, reduce that inflammation. So you're reducing the inflammation, you're releasing the bronchoconstriction, or you're having bronchodilation, and that helps the asthma kind of subside. Prevention and control, huge. Again, another important reason to have a medical home, someone that can manage asthma as a chronic disease. I do want you to read through this asthma treatment plan. Here's a stepwise approach to asthma management. A lot of times they have the asthma action plan, and I think this is kind of a take on that. Things that you might see during an asthmatic attack, you're going to hear wheezing. And if you don't hear wheezing and you know this child is asthmatic, that could be even worse than hearing wheezing. So make sure you auscultate really, really well. There's your asthma action plan. Nebulizers or inhalers are used to deliver albuterol and inhaled steroids or inhaled antibiotics. So this is a very old version of the nebulizer, but basically that's what it looks like. If the patient is not old enough to hold the mouthpiece in their mouth, then they need a mask. All right, this talks about meter dose inhaler. I would know how to teach a patient to administer a meter dose inhaler using a spacer always. This is a discus. Advair comes in a discus. I think there's another medication now that comes in a discus. It's a powder thing. It pops a little powder pellet open and you inhale the powder. Turbohaler, same kind of concept. All right, your peak flow. Peak flow is something that's measured in respiratory patients, especially asthma patients. And a lot of times it's done on a daily basis. So when you see 80% of your personal best, you're green. 50 to 80% of your personal best, you're yellow. And then less than 50%, you need to get some treatment on board. Here's some information about using a peak flow meter and how to do that. There's also a good YouTube video about using a peak flow meter and using a nebulizer. So if you'd like to, I'll search those out for you and I'll put those up. Asthma education and promoting normalcy, again, two very key points. Okay, so make sure you read through those. Chronic lung disease, we talked a little bit about that already. Cystic fibrosis. So let's see if there's anything that we've missed on cystic fibrosis. Again, it is a GI and respiratory illness or disease. It is genetic. You have to have 2 copies of the gene in order to have that. If you have 1 copy of the gene, you're just considered a carrier. Pancreatic enzymes are needed because of the blockage of the pancreatic duct. Can't dump those enzymes into the gut, so we have to supplement. Secretions, thin those secretions. Water, hypertonic saline, CPT, chest physiotherapy. That's what CPT stands for. Okay. The main goal of treatment of CF is to minimize the infections. Fibrosis just means hardening. So the hardening of the lungs is from chronic infection. So you want to prevent the infections to prevent the fibrosis, and your lung tissue is going to be much more compliant. Keeping kids active, very important in CF. All right, and here's some of the patho behind CF. It talks about the GI tract and the respiratory tract, so read through that. Know that your vitamins affected are A, D, E, and K. Know that if you have a chronically skinny baby that has trouble gaining weight, then you might think about CF. All right. Let's see if there's anything. This does talk about some assessment with CF, and basically you're assessing them like a respiratory patient. Okay, you're going to get a rate. The only thing additional you might get is the pulmonary function test. This talks about CPT and how you can perform it. Maintaining good weight, maintaining good nutrition is the focus of CF treatment. Again, monitoring their weight, monitoring them on the growth charts, very, very important. They do test for CF now at the newborn screen. So we're diagnosing a lot of CF patients very early, sometimes even in utero. If there's a family history or if mom and dad are both known carriers, then they might do a test before the baby's born to know what they're dealing with when the baby's born. But if they catch it on a newborn screen, treatment can get started immediately to kind of prevent all of those infections that might happen before the diagnosis if that wasn't part of the newborn screen. All right, and apnea, we said apnea is cessation of breathing for longer than 20 seconds. Know that definition. We used to call patients that came in, like babies that came in, acute life-threatening event. A lot of times it was aspiration or reflux that caused them to stop breathing for more than 20 seconds. So a lot of times that's how how reflux is diagnosed with episodes of apnea. All right, here's some information on SIDS. Unfortunately, that is a fact of life, so make sure you read through this, especially the prevention part. No sleeping in bed with mom and dad, okay? No pillows, no stuffed animals, back to sleep, okay? All of those really important. There's an apnea monitor on this patient. If the patient goes home with known, like if they're a NICU baby and they go home with periods of apnea, they may be on an apnea monitor to kind of alert mom and dad if they stop breathing for more than 20 seconds. They also always go home with CPR training. All right, babies with trachs. You might run into these in the hospital. We have every year we have to check off a competency that we can change a trach out. So these are actually fairly current looking trachs. Again, if you see one of these in the hospital, don't be afraid of it. Get your instructor and make them take you to show you how to take care of them. Always have a spare trach at the bedside. One size, or the trach that the patient has, the size that the patient has, and one size smaller. Remember that. Always have a bamboo bag at the bedside if you have a patient with trach. Usually these are chronic kids. Okay. Sometimes, like if you have an epiglottitis, you might have a trach for a bit and they may take it out. But most of the time, these are chronic patients with chronic diseases that have a trach. All right. Emergency equipment to have at your bedside. Always, always, always have this equipment at the bedside. Parents need to carry this with them wherever they go. They usually have a little kit that they take with them. Here's a nursing procedure about trach care. Now again, this may vary from facility to facility. So if you are going to take care of a trach patient, make sure that you know the proper procedure in your facility. And finally, last but not least, here's care plan for your patient with a respiratory disorder. Again, if you just think about it, clear the airway, clear the airway, clear the airway. That's what you need to focus on. Assessment. So with the system, you need to know what you're looking at, what you're looking for. Okay, so you need to know good assessment. Interventions. What am I going to do about it? I'm going to clear the airway. I'm going to give a bronchodilator to open up the airway. I'm going to trach my patient if they have epiglottitis. Okay, so what to look for, what to do about it, and what to reevaluate after you've done your intervention, and what I can teach the parents. Okay. So think of those 4 things. You can put everything into one of those categories. Care plans do a great job of that, and you will be fine. All right, that's all I got today. I'm sorry it took so long. It's an hour and 4 minutes, so you can break it up into if you'd like. And y'all have a good day.